What's up, everyone? Jeff Lewis of Lewis Physical Therapy and Sports Rehab here. I want to talk to you today about how we go about differentiating between a UCL injury and a Flexor-Pronator injury in baseball players, specifically pitchers, that come through our door. The reason I want to talk about this is because both injuries can result in significant lost amount of time, but it's important to be able to distinguish between the two because that will ultimately dictate your course of treatment. Now, what I will say before we get into the specifics here is these injuries don't always happen in silo or individually. They sometimes happen together. So that's part of just one thing you want to be thinking about in your exam of how you go about differentiating one versus the other or determining if there's a little bit of both at play here. So starting off with our UCL injury, your ulnar collateral ligament, that's the one that we always talk about from a Tommy John injury standpoint that we hear, or Tommy John surgery that we hear all the time about. And it's really the big one that results in a significant amount of time, usually around 12 to 16 months on average if you have surgery from that standpoint. Not all UCL injuries require surgery, but when they do have surgery, it's a significant amount of time lost. So when we go about determining whether a pitcher is dealing with a UCL injury, there's a couple things that we want to be on the lookout for. So specifically, where are they feeling, where are they tending to palpate, where are they feeling their pain? So if I have my elbow here, if I have my elbow extended here and you kind of find that bone on the inside there, your medial epicondyle, and you kind of find the meat of that kind of tissue right there, that's your Flexor-Pronator. So it's going to be hard for you to evaluate the length of that UCL in this position here because that muscle group is taut. So what I like to do, you want to have at least a 30-degree bend. I like getting guys in their kind of 90-90 layback position on the table because it moves that flexor out of the way. And what I'm going to do is I'm going to go posterior, so just behind that medial epicondyle, and then just distal to it below. And I'm going to find kind of the length of that UCL right in here, going from that medial epicondyle down to the sublime tubercle on the ulna. So that's the difference in the palpation more than anything for differentiating UCL from your flexor. And again, not only do you want to identify on palpation if that's where they're feeling it, but also when you go through your testing, if they have pain, if that's where they feel it as well. Now, the next thing we want to look at is determining the amount of laxity in their elbow. Now, pitchers in particular are going to have laxity in their pitching elbow just from the demands of pitching, especially if they've been doing it for a long period of time. So there's a lot of ways you can measure laxity in the elbow. So historically, the traditional valgus tests are you have them standing, you're giving a valgus stress here, and then at 30 degrees here. Those are not bad tests. I do that. The problem is that you can get some compensatory rotation at the shoulder versus just isolating the elbow. So I think the prone valgus test is probably your best way to determine laxity in this position. So you're going to have them lying on the table, and I'll explain it here, but if you look up a video of prone valgus stress test on online or YouTube or whatnot, you'll find a video of it. Is you have them on the table, their arms off the edge, forearms supinated, and you're providing that valgus stress at about 25 to 30 degrees of elbow flexion. That's going to give you a good idea of how much gapping and opening is occurring at this elbow and if they have pain with it as well. But we want to make sure we're comparing to the other side to determine what's abnormal versus normal. So increased laxity on their stress testing and probably some pain as well with that. Now, in terms of where they're having pain during the throwing motion, what I will say is with both UCL and Flexor-Pronator injuries, you can have guys either have pain with both of those up at layback or acceleration or at release. Traditionally, though, I would say, by and large, most guys with UCL injuries are having pain at layback, getting all the way into ER and that early acceleration. Layback is going to be providing some of the greater valgus torques and stresses on that elbow. So that's where we typically see that there. And then when they have to essentially kind of close down that elbow to come out of it. So layback early acceleration, again, it doesn't always mean it's UCL, so that's why I'll put an asterisk next to it. But it's definitely getting us to think, okay, is this UCL involved here? And then your valgus testing. So two main tests that we look at here. And both of these are done with the athlete lying supine, their arms at a 90-90 position off the edge of the table in max external rotation. So moving valgus. So in this case, I'm going to apply a valgus stress, and I'm going to move their arm through this range here. And typically with ligament injuries, we see pain in that medial epicondyle on that distribution from that 70 to 120 degrees of elbow flexion. Now, if I have a guy that I get them out to like that last 10 degrees, so like 10 to 0, and they're like, oh, that hurts. Well, now I want to ask, where are they feeling pain? Is it ligament or is it more posterior elbow now? And if they're like, yeah, you know what, I don't feel it on this spot here, but I'm getting a lot on the back of the elbow here, that tells me there might be a little bit more of a posterior compartment issue going on at play here. That's outside of the scope of this video. Just kind of goes to show there's a lot of different things you have to differentiate in the elbow. But valgus testing, so moving valgus. And then the last one is your milking maneuver. So again, you're in this position here. I will grab the athlete's thumb, and I will take that thumb and pretty much pull them into max layback. And again, if they have a UCL injury, they are likely going to feel that pain in that medial epicondyle along that distribution. So those are some of the big things we're thinking of for UCL. Now, one thing we have to talk about when we're evaluating the UCL is we need to evaluate the integrity of the ulnar nerve. So, are they starting to get some numbness and tingling down their fourth and fifth finger? Are there temperature changes in those fingers more than anything? A common test we'll do is we'll go in that cubital tunnel right behind that ulnar nerve right behind the medial epicondyle where that ulnar nerve lives, and we'll tap on it there. And if it's an irritated ulnar nerve, when you tap on that, they're going to get some paresthesia, some numbness tingling down their fourth and fifth fingers. I will also evaluate the medial head of the tricep because that's where that ulnar nerve spits out of, just to kind of determine, is it a hot spot from a trigger point standpoint? And this is just more gaining more information more than anything. But that's what I want us to think about here more than anything. Flexor-Pronator injuries, moving on to that. So we talked about before how, with the UCL, that palpation is going to be, posterior and distal to that medial epicondyle. Well, how you find the Flexor-Pronator mass is you go from that medial epicondyle, you drop down, so not back, you just drop down, and then you go right forward. And now you're on the meat of that Flexor-Pronator. So I will literally go UCL first, posterior, distal, say, hey, is your pain there? No. And I will literally from there just kind of move forward, right forward like that. And they're usually, if it's a Flexor-Pronator, they're like, yes, that's where I feel it. And then I want to evaluate along the length of the flexors and the pronator itself. But that's how we differentiate from a palpation standpoint there more than anything. Now, for an isolated Flexor-Pronator injury, all your valgus and laxity testing from a UCL is all going to be normal. So they might have their kind of quote-unquote normal laxity where, that elbow has a little bit of opening to it, but it has a good end feel. It's not painful. It's not flying open. So that's why I kind of put that quote-unquote normal laxity there because it's normal relative to pitchers. And they're not going to have any pain on valgus stress testing. So no pain with the prone valgus, no pain with moving valgus or milky maneuver. Those are all fine. Now, in terms of pain of where they're feeling this more than anything, it's typically pain at release. So when we look at the throwing motion, as they're essentially going into at early acceleration, they're getting a very forceful eccentric contraction of those wrist flexors. And then as they go into release, they're getting that very forceful, powerful wrist flexion component. And that now, depending on the pitch too, some guys will have more degrees of ulnar deviation and pronation and whatnot, but it's typically at release when you see that last little bit of that finishing component. So that's why we ask guys like, hey, are you getting your symptoms back here? Are you getting it at that last little bit of release when you're kind of getting on top of the balls, whether it's fastball, slider, curveball, changeup, whatever that might be. But historically, with pain at release, it doesn't always mean it's just Flexor-Pronator, but that's a little bit more what I'm leaning towards. And then again, this is one piece of the puzzle when we're taking all this into account. And then pain with strength testing. Now, I will say, in a very acute ligament injury, you're going to have pain with all these different types of, strength testing for the wrist and the forearm. However, in more chronic cases, you might not necessarily have pain with all these. But historically, with Flexor-Pronator, you're going to have pain with a wrist flexion component, a pronation component, the FDS, so your fingers, and then FCU is this ulnar deviation component. Now, it can be a combination of the two. It can be just one. It could be just the others. Not only do you want to evaluate all these, but what I'm going to do here is you want to evaluate with the elbow flexed and extended. Okay, so you want to evaluate in both of those positions there because one, in the flex position, the Flexor-Pronator group is going to be on slack. In extension, it's going to be fully taut more than anything in that fully out extended position. So I want to make sure we're doing it in different positions here. I also like testing these in that layback early acceleration position. So I'll get them in 90-90. I'll test positions here. I'll also get them almost out in a little bit more of a valgus and then have them contract there more than anything. So that is why we want to really try to dial in that evaluation of Flexor-Pronator versus UCL. And the reason we have to look very close to the Flexor-Pronator is because if you miss a Flexor-Pronator injury, you are going to be putting the UCL at injury. So your Flexor-Pronator is the primary dynamic stabilizer for the medial elbow. So your primary static stabilizer is your UCL to prevent valgus stress. After your UCL, your Flexor-Pronator is what kicks in to minimize valgus stress in joint gapping, specifically your FDS and your FCU. So that's why we have to make sure we really isolate this here more than anything. If we miss this and we try to push through it, we're potentially now putting the UCL at risk. Now, one thing I want to talk about over here is just some other general things that we're talking about in our evaluation more than anything. That's kind of telling us, all right, there's some type of medial elbow pathology, but we have to kind of like decipher it a little bit more. When we start to hear guys saying their velocity is going down, they're having a loss of command, so they can't locate their pitches. So, you have a guy that say their pain is more at release more than anything. They might be kind of missing high because they can't get out in front as much, and they're maybe missing over here, or they're missing more arm side. So these are just things that we're listening to more than anything. Now, one thing that I want to talk about here is the changing of symptom location. So I'm going to go back to the UCL injury here. So when we look at UCL injuries, you have your acute versus your chronic. Your acute injuries are, they feel a pop, it's a single pinch, they feel this pull, sharp pain, whatever that might be. But the changing symptom location in chronic UCL injuries is crucial because I honestly see that more than anything. And what I'm talking about there is when you have a chronic UCL injury, that UCL is just not able to stabilize as well as it is over time. So say you have a guy that at first, they're feeling their symptoms on the medial elbow. And then after a couple of weeks or whatnot, they're still going. But now they're like, you know what? Hey, I'm getting more sore on the back of my elbow. I'm getting more sore on the outside, the bicep and whatnot. And when that kind of starts to spiral and snowball like that, that's kind of now starting to think, okay, this ligament has probably reached its capacity. It is not limiting valgus stress anymore. So the body is trying to have to find stability elsewhere. Is it finding stability in the nerve, in the flexor-pronator, in the back of the elbow, the olecranon, from a bone standpoint? Is it getting more lateral compression because you're getting so much valgus stress there? So this is just one thing we want to think about in these kind of chronic elbow cases. Another thing I will say is the recovery component. So what I mean by that is you have a guy that, they have one start, they wake up the next morning like, man, I'm pretty sore today. Like, it takes them a day or so to get kind of back on the horse and get going. And we're just thinking about it more than anything. But, after each progressive start, it goes from one day of being able to get kind of back on the horse to 2 days, to 3 days, and then they just can't recover from their starts. So when that happens, that usually is telling me there is some type of medial elbow pathology going on here. And then it's our job to determine, again, is this UCL versus flexor? And we've already done an evaluation at that point when they're starting to have those symptoms, but we're just always continuing to reassess this more than anything. So these are all the things that you want to take into account. If you're a clinician, you're seeing baseball players, when you have a guy come in with medial elbow pain, this is what you want to look at by and large for determining UCL versus flexor-pronators. If you're also looking for a good article, Kevin Wilk and them put out a good article that also kind of differentiates some of these too. So if you just kind of need seeing more like in writing and whatnot, they put out a good article from that standpoint too. I think it gives a great overview of just how you identify the two. And then you as a clinician will find different kind of little things that you find in just your practice the more you see these in person. But if you're an athlete or the parent of an athlete that's dealing with some medial elbow symptoms and you're just trying to figure out what it is, first off, get evaluated by a baseball-specific clinician, whether it's an MD or a PT. And then just these are some of the things that we take into consideration there. So if you're dealing with elbow pain and or your child is dealing with elbow pain, you have questions on what that might be or what the rehab looks like, drop your questions below in the comment section or subscribe to our channel for more content like this.